For participants joining by Zoom, a few quick reminders. Please keep your line muted unless you're recognized to speak. When the discussion period opens, use the raise hand function in Zoom if you would like to be recognized. Questions will first be taken from voting ACIP members and ex officio members, followed by liaison representatives as time permits. The Advisory Committee on Immunization Practices is a public body, and transparency and engagement are central to our work. This meeting includes 2 oral public comment sessions, today at approximately 3:50 p.m. Eastern and tomorrow at approximately 1:45 p.m. Eastern Time. Requests to provide oral comments must be submitted online in advance. Priority is given to advance requests, and when demand exceeds available time, speakers are selected through a blinded lottery. 19 speakers were selected for this meeting and have been notified. We thank all who expressed interest in sharing comments. Members of the public were also invited to submit written comments through regulations.gov. The docket number for this meeting is CDC-2025-0454. More details on the public comment process are available on the ACIP meeting website. In accordance with ACIP policies and procedures, members agree to forego certain vaccine-related activities during their tenure. For activities that may enhance expertise, the CDC has issued limited conflict of interest waivers. For example, members conducting vaccine clinical trials or serving on data safety monitoring boards may present on those vaccines but may not vote on related matters. For other vaccines from the same company, members may join discussions but must abstain from voting. At the beginning of each meeting, ACIP members disclose any relevant conflicts of interest. We will now proceed with roll call, beginning with ACIP members, followed by ex officio members and liaison representatives. For ex officio members and liaisons, I will call your organization. Please respond with your full name and confirm your presence. We will begin with the ACIP chair, followed by the members in alphabetical order.
Good morning. My name is Martin Kulldorff. I have no conflicts of interest.
Thank you, Dr. Blackburn. And if you'd like to say something about the background, you can do that as well.
Awesome, great. My name is Hillary Blackburn, PharmD MBA, and I'm honored to join you all as the first pharmacist to serve as a voting member of ACIP. I currently serve as Director of Medication Access and Affordability at Ascension RX, and I earned my Doctor of Pharmacy degree from the University of Mississippi School of Pharmacy and completed a PGY1 residency at the University of Mississippi Medical Center. Over the last 15 years, I've worked across hospital, community, specialty pharmacy, and health plan settings. And as a practicing pharmacist, I have administered hundreds of vaccines and completed national immunization certification. I've held numerous leadership roles within professional organizations, including at the national and state level. Been a dedicated preceptor for student pharmacists from multiple colleges of pharmacy and serve on the Dean's External Advisory Committee for 2 colleges of pharmacy. I'm honored to bring a pharmacist perspective to the important work that we do as part of the ACIP, and views are my own, not of my employer or other groups of which I am a part.
Thank you, Dr. Griffin.
Good morning. My name is Dr. Evelyn Griffin. I'm an OBGYN from Baton Rouge, Louisiana. I am board certified by the American College of Obstetrics and Gynecology, by the American Board of Lifestyle Medicine, and the Institute of Functional Medicine. I was amongst the first to be a gynecologic robotically assisted surgeon in the nation. In my clinical practice in obstetrics, I had been part of initiatives for maternal immunization, including diphtheria, pertussis, and tetanus. And in my overall practice, I feel like if I was to be given a label, I would call myself pro-informed consent, because of medical ethics for discussing risks, benefits, and alternatives with the patient. During the pandemic, I myself was COVID vaccinated. I am honored to be on this community. Thank you for having me.
Good morning. I'm Joseph Hibbelin. I'm a board certified psychiatrist coming to this committee in part for the immense mental health aspects of vaccinations and diseases. I'm a distinguished visiting professor at the University of Bristol in the UK. I have 30 years of research experience at the NIH in basic science, animal, human, and epidemiological studies and data. I have 285 publications with an impact factor of 30. I had to look that up, figure out what that meant. Apparently, it's not only exceptional, but rare. So I didn't know about that about myself. The critical issues I bring to the committee are an appreciation of calculating risks and benefits of getting vaccines and not getting vaccines, backgrounds in immunology, neurodevelopment, and translational sciences. I've been on panels from NATO to the WHO to the National Academy of Sciences twice, to the dietary guidelines twice, to UK parliamentary inquiries, and the Department of Defense and the American Psychiatric Association. Thank you. And I have a neutral mind towards vaccines, approaching this with a scientific equity.
Thank you. We'll skip, for Dr. Levy will join us momentarily. Dr. Malone.
Thank you. Dr. Kirk Mellahone, I first got my PhD from UCSD in physiology and pharmacology, with my thesis being on the mechanisms for inflammation in myocardium. I went on to medical school at Jefferson Medical School, did my residency at Travis Air Force Base in the United States Air Force, then went on to do my pediatric cardiology training at UCSD Rady Children's Hospital in San Diego. Following that, I was served as a pediatrician and pediatric cardiologist in the Air Force. I also served as a flight surgeon and did 2 tours in Iraq as a flight surgeon. I have been board certified in pediatrics and pediatric cardiology for over 20 years. I have experience in vaccinating children and international medicine in over 23 countries, involving those without access to vaccinations. And I currently care for many of those who are suffering from post-vaccine syndrome. Currently, I am a clinical associate professor at Texas A&M College of Medicine, excuse me, and performing inpatient and outpatient cardiology at a children's hospital in Texas. I have co-authored 2 articles on the risk and benefits of COVID-19 vaccines, specifically regarding post-vaccine myocarditis. And it's an honor to be here. Thank you.
Mention whether you have a conflict of interest.
No conflicts of interest.
Thank you. Dr. Robert Malone.
I'm Robert Malone. I'm a Maryland licensed physician. I hold a MD from Northwestern University, a master's degree from UC San Diego in the Salk Institute, Molecular Biology and Virology Laboratories. I had disclosures and inventions, multiple patents in the late 1980s and early 1990s having to do with DNA and RNA vaccines. I've been involved in both bench research with numerous discoveries while I was teaching pathology to medical students for many years. I've also completed a fellowship in both pathology and a fellowship in global clinical research at Harvard. I've been involved in designing, developing, and providing oversight for approximately 40 phase 1 clinical trials, 20 phase 2 clinical trials, 5 phase 3 clinical trials. served as medical director and medical monitor on phase 1 and 2 and 3 clinical trials, mostly focused on vaccines. I am a vaccinologist. I've spent most of my career developing vaccines. And that experience includes significant work with the Department of Defense, supporting a variety of vaccine products. I originally started off in HIV vaccines. I served here in Georgia as head of clinical for a $330 million BARDA contract for developing cell-based influenza vaccines focused on the clinical aspect of that. I have experience in plague, anthrax, V, tularemia, tuberculosis, Ebola, Zika, ricin toxin, botulinum toxin, and engineered pathogen vaccines. I hold or have been granted a secret clearance by DoD. I have over 100 papers, something like 15,000 citations, and have really extensive experience in public policy as it relates to vaccines, including serving in multiple times as study section chair for typically large contracts at NIH, been an advisor to the World Health Organization on multiple topics relating to infectious disease, and made presentations at WHO about vaccine technology, particularly for influenza. I have no conflicts of interest. I thank the CDC and HHS for the opportunity to serve here as an unpaid member of the Advisory Committee on Immunization Practices.
Thank you. Dr. Meisner, joining us remotely.
Thank you, Mina. Let me say good morning or good afternoon or good evening. I'm delighted to have an opportunity to participate in the discussions today. I am an independent contractor with TNL Government Services supporting BARDA, and I'm a professor at the Geisel School of Medicine at Dartmouth. Thank you.
And please state conflict of interest.
Thank you. I have no conflict of interest.
Thank you. Pagano.
Yeah, good morning. I'm James Pagano, a retired emergency medicine specialist with over 40 years of clinical and administrative experience. Over the course of my career, vaccines have provided significant and at times life-saving benefits to hundreds of my patients. These have included tetanus, tetanus toxoid, flu, diphtheria, pertussis, hepatitis B immune globulin, and yes, COVID. I've also been vaccinated myself numerous times against all these diseases and toxicities. So I'm not anti-vax. I am pro the intelligent and informed utilization of these potentially life-saving medications in a manner that reflects the current state of the art regarding their benefits, the target populations, optimal dosing and timing, and yes, of their potential adverse effects in some people, and I have no conflicts.
Hi, my name is Vicki Pebsworth, and my career began over 45 years ago. I started as a bedside nurse where I took care of patients who were sick with vaccine preventable diseases, and I gave lots of vaccines. I eventually went on to get a degree in public health and health services organization and policy, and also nursing at the University of Michigan. I am recently certified in bioethics. I have previously served on 2 other vaccine policymaking committees for nearly 10 years. I was with the Food and Drug Administration's VRBPAC committee, the Vaccines and Related Biologic Products Advisory Committee, and also served on 2 subcommittees at the National Vaccine Advisory Committee, the Vaccine Safety Working Group, and the 2009 H1N1 Vaccine Safety Risk Assessment Working Group. I've also served as a consultant to the CDC's Board of Scientific Counselors and also to the Institute of Medicine on the topic of vaccination and public trust. I have published peer-reviewed literature, and I serve as a peer reviewer for a couple of journals on topics related to vaccination, vaccine uptake, the effects of state laws, and vaccine safety. I currently volunteer as a director at the National Vaccine Information Center and the National Association of Catholic Nurses. My comments reflect my own opinions and not necessarily those of the organizations I am affiliated with, and I have no conflicts of interest.
Thank you, Dr. Paul.
Am I next?
Yes, please.
I'm Raymond Pollock. I'm a semi-retired consultant and former professor and head of the abdominal organ transplantation at the University of Illinois. I was also a principal investigator in multiple clinical trials, as well as a principal investigator in NIH-sponsored research in transplant immunobiology. I'm happy to be here and thank you for the opportunity to be of service, and I have no conflicts of interest.
Thank you, Dr. Stein.
Hi, I'm Dr. Kathy Stein. I'm a professor of epidemiology. My PhD is in epidemiology and biostatistics, and I have a 20-year career focused in infectious disease epidemiology with over 115 peer-reviewed publications and several review papers and other things besides. I've also done some work in bioethics, especially focusing on informed consent. And I've mentored several master's and PhD students who have gone on to careers in public health and medicine. Much of my infectious disease research has been collaborative in the field of immunology and thus has had implications for vaccine design. I am a professor of epidemiology at Case Western Reserve University. My views are my own, and I have no conflicts of interest to report.
Thank you. We'll move on to our ex officios, starting with CMS. Please provide your name.
Andrew Johnson, Centers for Medicare and Medicaid Services.
Thank you. HRSA.
Captain Reed Grimes, Health Resources and Services Administration.
Thank you. IHS.
Matthew Clark, representing the Indian Health Service.
Thank you. NIH.
Michael Carilla, representing NIH.
Thank you. And FDA.
Tracy Beth Hogue, FDA.
Thank you. And we'll go back to Dr. Retzef. If you please do your introductions and state if you have any conflicts.
So first, I don't have any conflict of interest. I'm Retzef Levy from MIT. I'm a faculty there from 2006. I have a PhD in operations research. And I've been working for most of my career, academic career, on trying to think about risk-benefit trade-offs and optimization of them in many complex systems that operate under a lot of uncertainty with the great consideration to risk. And a lot of my work has been focused on human health. I've been working for many, many years with clinical teams on the ground, trying to optimize clinical and operational processes in large healthcare systems, working extensively with healthcare data. I've been working on using data to optimize the quality and safety of the manufacturing of biologic drugs, developed drug safety models, epidemiological models, also worked on issues related to access to healthy food, agriculture and food supply chains and their impact on health. And I'm honored to be here and work with my colleagues on the committee and the CDC and FDA today and tomorrow.
Thank you. I will now call the liaisons, and please state your name if you're on the phone. American Academy of Family Physicians.
Good morning, Dr. Laura Morris, representing AAFP. Thank you.
American Academy of Pediatrics, American Academy of Pediatrics, American Academy of Physician Associates.
Good morning, Dr. Sandra De Palma, AAPA.
Thank you. American College Health Association.
Good morning, Ashley Halbritter, American College Health Association.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists. American College of Obstetricians and Gynecologists. American College of Physicians.
Good morning, Dr. Jason Goldman, board certified internal medicine specialist with over 25 years of clinical experience, clinical affiliate professor of general internal medicine at Florida Atlantic University, and president of the American College of Physicians, present.
Thank you. American Geriatric Society. American Geriatrics Society. America's Health Insurance Plans.
Good morning, Lori Kaloya, present.
Thank you. American Medical Association.
I'm Dr. Sandra Freihofer, practicing general internal medicine physician in Atlanta and adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Barbara Resnick, I'm present representing the ANA. Thank you.
Thank you. American Osteopathic Association.
Good morning, Masood Mahmoudi, American Osteopathic Association.
Thank you. American Pharmacists Association.
Hi, good morning. Dr. Kelly Good, representing the American Pharmacist Association. Pharmacists and pharmacy personnel are the most accessible healthcare providers and serve as the primary immunizers for patients across the country. Our association represents these professionals and is committed to supporting science-driven, evidence-based recommendations that enhance public health. I appreciate the opportunity to contribute to this ACIP meeting. Thank you.
Thank you. Association of Immunization Managers.
Hi, good morning. Molly Howell, representing AIM.
American Immunization Registry Association.
Good morning, Rebecca Quayle, representing ERA.
Association for Prevention, Teaching, and Research.
Good morning, Christy Mullinger, representing APTR.
Thank you. Association of State and Territorial Health Officials.
Good morning, Dr. Meredith Allen, representing ASTO.
Thank you. Biotechnology Innovation Organization.
Phyllis Arthur, representing Bio. Good morning.
Thank you. Council of State and Territorial Epidemiologists.
For Christine Hahn, representing CSTE.
National Association of County and City Health Officials.
Yes, good morning. My name is Dr. Judith Schley. I'm a family physician at the Public Health Institute at Denver Health, and I am representing NACHO, which supports 3,000 local public health agencies in our country.
Great, thank you. Canadian National Advisory Committee on Immunization.
Matthew Tunis, present.
Thank you. Infectious Disease Society of America.
Flor Munoz, Infectious Disease Society of America, present.
Thank you. International Society for Travel Medicine. International Society for Travel Medicine. National Association of Pediatric Nurse Practitioners.
Good morning. This is Stacy Buchanan, doctorally prepared nurse practitioner, as well as instructor, professor at the Emory School of Nursing.
Thank you. National Foundation for Infectious Diseases.
This is Dr. Bob Hopkins, medical director for NFID. We're here for the science and for our patients. Thank you.
Thank you. National Medical Association.
Good morning. This is Naima Joseph with the American College of Obstetricians and Gynecologists. I was not unmuted previously, but we are present. Thank you.
Great. Thank you so much. National Medical Association. National Medical Association. Pharmaceutical Research and Manufacturers of America.
Yeah, good morning. This is Dr. Michael Ibarra. I'm a board certified and practicing emergency physician and chief medical officer at Pharma.
Thank you. Pediatric Infectious Diseases Society.
This is Grant Paulson with Pediatric Infectious Diseases Society.
Thank you. Society for Adolescent Health and Medicine.
Hi, this is Amy Middleman representing SAM and looking forward to hearing scientific evidence to recommendation presentations that are so critical prior to any public health recommendation. Thanks so much.
Thank you. Society for Healthcare Epidemiology of America. Society for Healthcare Epidemiology of America. Okay, thank you. I will turn it over to the chair.
Thank you so much. Good morning. I wish to welcome all of you with a special welcome to the 5 new voting members of this committee. Most of all, I would like to welcome members of the public who are listening to these proceedings. We are currently experiencing heated controversies about vaccines, and the key question is, who can you trust? Here's my advice. When there are different scientific views, only trust scientists who are willing to engage with and publicly debate the scientists with other views. With such debates, you can weigh and determine the scientific reasoning by each side, but without it, you cannot properly judge their arguments. For this reason, I lament that the American Academy of Pediatrics has ended their participation as a liaison member of this committee. Neither have they accepted my invitation for an open public debate on vaccines with equal time for each, nor an invitation for private conversations. A few weeks ago, the CDC director was removed and 3 members of the CDC leadership resigned, citing divergent opinions about vaccines. On vaccines, this committee is the key advisor to the CDC director, but during her short tenure, she never contacted me as the ACIP chair about any of her questions or concerns, which would have been natural if she had such concerns. Neither was I contacted by any of the 3 CDC leaders who subsequently resigned, except for receiving a good suggestion by Dr. Daskalakis during the June ACIP meeting, which we adopted. Of the 4, Dr. Jernigan has done important research on influenza vaccines, but the others are not vaccine scientists. Why would these CDC leaders ignore us instead of seeking advice from fellow scientists who have spent decades studying vaccines? With other CDC staff, I've had frequent and excellent interactions since I became the chair of this committee, as well as going 20 years back working with CDC. Some are very good, and the rest, they are fantastic. All are hardworking, and I cannot thank them enough for the work they're doing. After the 4 CDC leaders departed, 9 former CDC directors wrote an op-ed in New York Times, falsely claiming that members of this committee are quote, unqualified individuals with, quote, dangerous and unscientific views. This committee has a wide variety of vaccine expertise. Other committee members have already described their own credentials. As a professor at Harvard Medical School, I develop epidemiological and biostatistical methods for post-market vaccine safety studies that CDC regularly uses, including 3 methods used for CDC presentation at our last ACIP meeting in June. I have authored dozens of scientific articles about vaccines with vaccine scientists at CDC, FDA, and leading universities. And I dare to think that my contributions to vaccine research is highly regarded by my colleagues. Since we authored the same scientific articles, are my co-authors also unqualified and unscientific vaccine scientists? Of course not. The majority of our many vaccine safety studies did not find problems with vaccines. So by dismissing us as unscientific, the former CDC directors are de facto questioning not only us and our scientific research, but they're also questioning the safety of many childhood vaccines that we have shown to be safe. The fact is that we are honest vaccine scientists that let the data speak whether the results go in one direction or the other. That is always how science should operate. In April 2021, when CDC instituted a pause on the Johnson & Johnson vaccine against COVID, despite a vaccine shortage during the middle of a major COVID wave, I was the only vaccine scientist to publicly object to that decision, one that I believe led to unnecessary death among older Americans. After noticing blood clots in post-vaccination young women, it was reasonable to advise them to take another vaccine. But the decision to remove the Johnson & Johnson vaccine from all ages must be viewed as one of the most disastrous vaccine decisions ever made by CDC. Because of my public objection, I was fired from the CDC committee that was monitoring the safety of COVID vaccines. But 4 days after firing me, CDC lifted the pause as I had suggested. At this time, I was clearly the most pro-vaccine scientist in the country, while becoming the first person fired by CDC for being too pro-vaccine, simply because I chose to debate the science rather than go along with the crowd. As this committee clearly stated at our last meeting, we strongly support the use of vaccines. At our last meeting, all our decisions were pro-vaccine. This includes the vote to remove mercury for vaccines. Mercury is a known toxin, just like lead and cigarette smoke, and we should minimize exposure to such toxins as the effect is cumulative. If you had to choose between buying similar hot dogs with or without mercury for your kids, raise your hand if you would pick the mercury-containing hot dogs. Nobody would? FDA has banned mercury from beauty products such as skin creams and soaps. Vaccines are more important than cosmetics. Since there are equally good mercury-free vaccines, removing mercury has only positive public health consequences, while increasing the integrity and trust in the vaccine program. One of the CDC leaders that resigned cited our vote to remove toxic mercury from vaccine as a reason for his resignation. I found that surprising. In contrast to that, I want to take this opportunity to thank the many mothers and fathers who over many years have fought hard to remove mercury for vaccines. You have falsely been called anti-vaxxers, but your stance is not only pro-children, but also pro-science, pro-public health, and pro-vaccines. The members of this ACIP committee are committed to reassuring the public and restoring public confidence by removing unnecessary risk and harms whenever possible. That is a pro-vaccine agenda. While all of Western countries recommend important vaccines, such as the one against measles, there's a wide variety in the recommended vaccine schedules. This does not make some countries anti-vaccine countries. The votes that we will take at this meeting falls well within the natural variability seen between countries. We welcome scientific critique of any of our votes, as there are gray areas due to incomplete scientific knowledge. But false accusations that we and other respectable vaccine scientists are unscientific and dangerous anti-vaxxers, that just adds legitimacy to anti-vax positions, damaging both public health and the confidence in vaccines. Such false accusations are only logical if their purpose is political. Again, I suggest that you should only trust scientists that are willing to debate fellow scientists with different views. I hereby invite each of the 9 former CDC directors to have a live public debate with me concerning vaccines. They are Drs. Besser, Cohen, Fauci, Frieden, Copland, Roper, Satcher, Schuchat, and Walensky. If they are unwilling to engage in an open and honest debate with a chair of this committee, that they are so severely criticizing, then I advise that you should not trust them. I also make the same invitation to the recently departed CDC leaders. If they want to be trusted, they should all accept. Thank you very much. And then we can proceed with the regular program of this meeting. We have a short update on working groups. We have a number of working groups that are working hard. And that's where a lot of the actual scientific work is going on. And you will hear from some of these, the deliberation of some of these working groups at this meeting. We also have two new working groups that we are setting up. One working group on vaccines in pregnancy, and the other one is the childhood and adolescent vaccine schedule. Most of the working groups consider a singular vaccine or a group of related vaccines. But it's also important to look at interaction effects, or if it's best to do one vaccine before another, or concepts of the whole vaccine schedule. So that is what this new working group will be looking into. And of course, vaccines during pregnancy, we always have to be very, very careful and considerate, as with not just vaccines, but with drugs or anything that we give to a pregnant mother because of risk of, for example, birth defects. So we will have those two working groups, and at some point in the future, we will be discussing the results of those working groups at these ACIP meetings. The first topic that we're going to talk during these meetings is the measles, mumps, rubella, and varicella vaccines. They're called MMRV. This is the vaccines where protecting against all these four diseases in one vaccination, in one needle. And that is the vaccine that was developed to replace two separate needles, one for measles, mumps, rubella, MMR, and then a separate needle for varicella to reduce the number of needles that a child receives. We're first gonna hear about the background on MMR from Dr. Arjun Srinivasan from here at CDC. So please.
Thank you, Dr. Kulldorff. Good morning. I'm Arjun Srinivasan, Acting Chief Medical Officer in the National Center for Immunization and Respiratory Diseases at CDC, presenting today the background on measles, mumps, rubella, and varicella vaccine. Do we have those slides? There we go. I want to mention up front that this presentation does not include data on safety related to M vaccine, either pre or post licensure. Those data will be discussed next by Dr. Su. Next slide, please. Measles, mumps, rubella, and varicella cause significant health burden pre-vaccine in the United States. Highlighted on this slide are several severe consequences of these diseases. During the last major rubella epidemic in the US in 1964 to 65, in 1 year, 11,000 pregnant women lost their babies, 2,100 newborns died, and 20,000 were born with congenital rubella syndrome that causes deafness, heart defects, and developmental delay. Before the introduction of the measles vaccine, each year an estimated 48,000 hospitalizations and 400 to 500 deaths were due to measles. Pre-vaccine, mumps was the leading cause of viral encephalitis and sudden onset deafness. And for varicella, each year in the early 1990s, 10,500 to 13,500 hospitalizations and 100 to 150 deaths were varicella related. Next slide, please. The introduction of vaccines to protect against these diseases in the form of monovalent and combination measles, mumps, rubella, MMR, or measles, mumps, rubella, varicella, or MMRV, coupled with attaining and maintaining high coverage rates for more than 90%, led to dramatic reductions in disease burden in the US. Elimination of endemic measles in 2000, elimination of endemic rubella in 2004, a 99% decline in mumps cases by early 2000, and a 97% decline in varicella incidence by 2019. Next slide. Two options are available in the US for measles, mumps, rubella, and varicella vaccination. Combination MMRV vaccine or MMR vaccine plus varicella vaccine. Vaccination is recommended as 2 doses with the routine ages being 12 to 15 months for the first dose and 4 to 6 years for the second. The MMRV vaccine available in the US, ProQuad, manufactured by Merck, was licensed by FDA in September 2005 based on non-inferior immunogenicity of the antigenic components compared with simultaneous administration of MMR vaccine and varicella vaccine. The efficacy of the measles, mumps, rubella, and varicella components of MMRV vaccine was previously established in clinical studies with the monovalent vaccines. At the time of MMRV licensure, the burden of disease for these diseases was too low to perform efficacy clinical trials in the US. Of note, immunobridging trials are an established approach for the development of vaccines. Next slide. Immunogenicity after the first dose of MMRV vaccine versus MMR plus varicella vaccines in children aged 12 to 23 months was assessed in 4 randomized clinical trials. 5,446 people received MMRV vaccine and 2,038 received MMR plus varicella vaccines at separate injection sites. In these studies, the endpoints assessed, seroconversion rates, and geometric mean titers were similar between the two groups and met the pre-established criteria for non-inferiority. Immunogenicity after the second dose of MMRV vaccine versus MMR vaccine with and without the varicella vaccine in children aged 4 to 6 years was assessed in 1 randomized clinical trial. 399 people received MMRV, 205 received MMR plus placebo, and 195 received MMR plus varicella vaccine. Findings also met pre-established criteria for non-inferiority. As you heard during the last meeting, an ACIP working group assessed the evidence for safety after MMRV compared with MMR plus V in 2008 and 2009. Their assessment on vaccine performance was that given the non-inferior immunogenicity, effectiveness was assumed to be equal. Next slide, please. This slide illustrates the timeline of recommendations for MMRV vaccine use in the US. Upon licensure in September 2005 for use in children aged 12 months through 12 years, MMRV vaccine was preferred over separate administration of MMR and varicella vaccines, consistent with ACIP recommendations at the time on preferred use of combination vaccines. In February 2008, a preliminary vaccine safety finding from 2 post-licensure studies that found an increased risk of febrile seizures after the first dose of MMRV vaccine led to ACIP removing the preference for MMRV vaccine use versus MMR and varicella vaccines for both dose 1 and dose 2. After further examining the safety and other evidence, including use of MMRV vaccine has the benefit of requiring 1 less injection than the alternative of MMR plus varicella vaccines, epidemiology of febrile seizures, parent and provider input, and consultation with ethics experts, in June 2009, ACIP issued updated recommendations. Next slide. These updated recommendations are the current recommendations and state that for the first dose of measles, mumps, rubella, and varicella vaccination at age 12 to 47 months, either MMR vaccine and varicella vaccine or MMRV vaccine may be used. Providers who are considering administering the MMRV vaccine should discuss the benefits and risks of both vaccination options with the parents or caregivers. At the time of the publication of the recommendations, CDC provided implementation guidance that, unless the parent or caregiver expresses a preference for the MMRV vaccine, CDC recommends that MMR vaccine and varicella vaccine be administered for the first dose in this age group. For the first dose at age greater than 48 months, and for the second dose at any age through 12 years, that is 15 months through 12 years, MMRV is generally preferred over separate injections of MMR vaccine and varicella vaccine. Next slide. No post-licensure vaccine effectiveness estimates are available for the MMRV vaccine used in the US. With measles and rubella being eliminated in the US, mumps and varicella at very low levels, there are not enough cases of disease or outbreaks in children to assess vaccine effectiveness in the US. Those vaccinated with MMRV or MMR and varicella vaccines continue to have very low rates of disease for measles, mumps, rubella, and varicella in the US. There have been no reports to CDC indicating concern for lower MMRV vaccine effectiveness compared to use of the separate component vaccines, consistent with the immunogenicity results seen in the clinical trials. Next slide. As far as utilization, MMRV vaccine accounts for 15% of first dose measles, mumps, rubella, and varicella vaccination among children aged 19 to 35 months. In most states, MMRV vaccine is used for about 10% to under 20% of first dose based on the first and third quartiles. In children aged 4 to 6 years, MMRV vaccine accounts for 75% of second dose vaccination. Next slide. To conclude, MMRV vaccine is one of the two options for vaccination of U.S. children for protection against measles, mumps, rubella, and varicella. As the ACIP assessed in 2008 and 2009, given the balance of risks and benefits of a first dose of MMRV vaccine compared with the first dose of MMR vaccine and varicella vaccine, and the importance of individual values and preferences in weighing these risks and benefits, maximizing choice is an important ethical principle, and decisions should be made by providers and parents or caregivers on a case-by-case basis. The two vaccination options, MMRV vaccine or separate injections of MMR vaccine and varicella vaccine, are considered equivalent in terms of protection against disease. Due to the current recommendations, most MMRV vaccine in the U.S. is among children aged 4 to 6 years for the second dose of MMR and varicella vaccination. Vaccination for measles, mumps, rubella, and varicella has led to at least a 97% reduction in all 4 diseases compared with the pre-vaccine era. Thank you.
Thank you so much for that presentation. From the members, do we have any questions or comments? Please, Dr. Milan.
Yes. Could you address the issue of how much adjuvant there is in an MMRV versus an MMRV and varicella that are used separately? Is the adjuvant similar or different?
Thank you. I'm going to ask my colleagues. We have a number of subject matter experts on the line who might have that information. Do we have the CDC SME room on the line? Does someone want to address that?
Okay, thank you. This is the NCIRD SME room. There is actually no adjuvant in either of the MMRV or the MMR plus V vaccines. Thanks.
Thank you. Joe?
As many of the members have been interested in risk-benefit assessments, you described a great deal of the benefits, and you mentioned febrile seizures as a risk. What is your opinion about the risk-benefit ratio of harm from febrile seizures or harm from side effects versus the benefits for the individuals in the population?
Dr. Su is going to present on the risk profile. It's not my position to comment on the risk benefits. Thank you.
Dr. Malone?
Yeah, I'd have a blanket statement regarding this topic area. Because of my prior work as an expert witness in the case of Kraling versus Merck having to do with mumps vaccines, because I signed an agreement to allow me to view extensive internal communications within two vaccine manufacturers, I am legally bound to not do any research or have opinions relating to these products because they include the mumps components. I just wanted to make that clear. I won't be voting, and I have no opinion on this consequent to pre-existing legal agreement from my years ago service as an expert witness in the case of Kraling versus Merck. Over.
Thank you for that clarification. Vicky?
Could you please clarify the difference in the amount of antigen for varicella in the two different options?
Let me turn to the CDC SME room and see if someone has the answer to that question. Thank you.
Hi, this is the NCIRD SME room. Can we have our backup slide number 12? Thank you. On the screen is the amounts, and we have another SME that can comment further.
Yeah, so the viruses and viruses,
Measles, mumps, and rubella is the same between MMR and MMRV. The V component of MMR. The V component of MMRV is the same virus as in single antigen varicella, but it's at a higher potency. You can see there are 399 logs PFUs versus about 3.13. So it's about 7 times higher the amount of VZV in MMRV. But the viruses are identical between the two vaccines.
I want to remind everyone to please state your name before you speak. Thank you.
Dr. Laway?
Yeah, I just as a follow-up question. So what is is there a biological or clinical reason for that different amount of antigen? Why in when it's being given as part of the MMRV, you need more versus separate? When it's given separately, what is the rationale for that?
Yes, this is Dr. Mona Marin from NCIRD. The initial clinical trials done by the manufacturers had the same amount of V from the single antigen in the MMRV. And the antigenic response, the immunologic response to the V component was suboptimal. Therefore, manufacturers did several clinical trials with different potencies of VZV, and they ended up with this as the best in terms of immunogenic and adverse events. When this issue was discussed in 2008, 2009, the evidence seemed to lead to a potential interference between the measles virus and the varicella zoster virus when they are put in the same vaccine, in the same syringe. We have a stronger response, immunologic response to the measles virus, more fever, more measles-like rash. But we have the same immunologic response after the single antigen varicella vaccine. So that's the reason. It was based on obtaining similar immune response.
And what do we understand of the mechanisms that explains that? Like, I understand the outcomes that you describe. It seems that you observed some outcomes, but do we have a deep understanding of the biological mechanisms that can explain why we see different responses with different vaccines and different combinations?
Yes. There is a final answer if the manufacturer is on the line and can elaborate further.
I think the manufacturer is scheduled to talk later, so maybe they can respond then if they're not available now. Okay, so we'll hopefully get that answer later on. So we're going to continue.
Corey Meisner.
Yes, I know. So before we continue with the next, one more question. Okay.
Yeah. Could you clarify the evidence on immunogenicity after the first dose of MMR if the majority of children develop protective antibodies after that initial dose? What is the scientific basis for recommending a routine second dose? Is it mainly to address primary vaccine failure, waning immunity, or both? And in that context, is there consideration in using antibody titers to verify response after the first dose rather than universally giving a second dose?
Let me ask the CEC SME room if someone has an answer to that. Thank you.
Hi, this is Oliver with NCIRD. Happy to start, and then we may have another SME who can add. So I would say that antibody titers are one aspect of the protective response. We do know that you see higher antibody titers after 2 doses, and so that is a component of it. We know, especially for the measles component, that the second dose helps pick up the kids who did not have a protective response to that first dose. So 2 doses are recommended. That was what was studied in many of the efficacy studies. And we know that 2 doses provides that additional protection overall.
And do you have the percentages?
So if you want to pull up extra slide 15. That has the seropositivity rates, the percent fold, rise in titer, and the geometric fold for multiple doses for the Proclad, which is the MMRV, or you can see the MMR plus Varivax in the bottom of each of those groups is the separate vaccines.
Do you have any from the primary? This is after the second dose. Do you have any after the primary dose? The sero uptake?
Yes, sorry, slide 13. That is after the.
Pretty good uptake.
Thank you very much. Dr. Cody Meissner, I have you for 2 topics. So if you address the MMRV Q&A now, and then the other one about the roll call, we'll do a little bit later.
Thanks, Dr. Kuldorff, Shirley. I want to thank Dr. Srinivasan, and I'm not pronouncing that correctly, but thank you for that overview. I wanted to add one comment in terms of the MMR component. And a lot of attention recently has been focused on the importance of the measles vaccine. But you also noted how important the rubella vaccine is. The last pandemic in the United States was in 1964 and 1965. And there were thousands of infections in pregnant women. And as you correctly pointed out, there were 11,000 fetal deaths and 20,000 infants who were born with congenital rubella syndrome. This is a devastating illness with congenital heart disease, retardation, eye problems. It's devastating. And then in 1969, Dr. Stanley Plotkin and his colleagues at the Wistar Institute developed the rubella vaccine. And that has been so effective. There are usually in recent years, fewer than 5 cases of congenital rubella a year in the United States. And those are primarily among women who were born in countries that do not administer the rubella vaccine. So I think it's important to focus on the absolute importance of making sure that every child is vaccinated against not only measles, mumps, and varicella, but also rubella. Thank you.
Thank you for that. And now Dr. Phyllis Arthur.
Thank you. No, actually, my question was answered. Thank you.
So thank you for that, and thank you for the excellent presentation and a good discussion. That's exactly what we want to have at these meetings. Before we go to the next presentation, I think we're going to do a roll call for missing persons to see if they have arrived late.
Thank you. American Academy of Pediatrics. American Geriatric Society. International Society for Travel Medicine. National Medical Association.
Hi, Ken Schmader for AGS.
Thank you. Society for Healthcare Epidemiology of America. Thank you.
And thank you for all of you. We are very grateful to have the vast majority of the liaison members here with us today. Dr. Cody Meissner.
Thank you, Dr. Kuldorf. I just wanted to express my appreciation for the societies that are particularly focused on infectious disease and vaccines. Dr. Goldman, Dr. Freihofer, Dr. Manoz, Dr. Paulson. It's so important that they're here. And as I said last time, I think it's a grave mistake for the American Academy of Pediatrics not to participate in these discussions. I think what the AAP is doing is moving themselves to irrelevance. And the importance of the AAP is going to wane if they refuse to participate in these conversations. Over.
Thank you very much. And now we're going to continue with the presentation on febrile seizures following MMRV vaccine by Dr. John Su. So please.
Thank you. Excuse me. Are slides being displayed on screen? Excellent, thank you. Next slide, please. So the ACIP chair requested from the Immunization Safety Office a presentation on febrile seizures post-administration of MMRV versus simultaneous administration of separate MMR and varicella vaccines by two different age groups, 1 to 2 and 4 to 6 years old. Please use data both from randomized trials and from the Vaccine Safety Data Link, or VSD, presented from the VSD project. The next slide, please. So the material in the next few slides have been covered by Dr. Srinivasan, so I'll be brief. MMRV vaccine was licensed in the US in 2005. Interim recommendations in 2008 removed the preferential recommendation for MMRV, and updated recommendations were made in June 2009. Next slide, please. During February 2008 through June 2009, the MMRV Vaccine Safety Working Group reviewed multiple sources of data, including 2 post-licensure studies from Merck and VSD. Next slide, please. In brief, the 2009 updated MMRV recommendations included guidance stating that unless the parent or caregiver expresses a preference for the MMRV vaccine, MMR vaccine and varicella vaccine be administered for the first dose in children aged 12 to 47 months. MMRV vaccine remains generally preferred for the second dose. For more details on these recommendations, please see the May 2010 MMWR recommendations and reports. Next slide, please. The next few slides provide some background on the MMRV vaccine and on febrile seizures. Combination vaccines, like the MMRV vaccine, decrease the number of injections a child receives, increase vaccine compliance, and increase vaccine coverage rates. Currently, the MMRV vaccine is licensed for children 12 months through 12 years of age. The vaccine is routinely recommended for the following ages. First dose is recommended at ages 12 to 15 months. The second dose is recommended between the ages of 4 and 6 years. ProQuad is the MMRV vaccine product licensed for use in the United States. Next slide, please. Febrile seizures are defined as seizures that occur in febrile children or children with fever. By 5 years of age, 2 to 4% of children have had at least one febrile seizure. They occur primarily between the ages of 6 months and 5 years, with peak occurrence between the ages of 14 to 18 months. Like any seizure, febrile seizures are distressing and can be worrying. However, febrile seizures are typically short, lasting less than 15 minutes, and the majority resolve without complications. Febrile seizures occur most commonly with fevers caused by common childhood illnesses, such as middle ear infections, viral upper respiratory tract infections, and roseola. They can be associated with any condition that results in fever, including vaccination. Also, a family history of febrile seizures increases the risk of febrile seizures. Next slide, please. Pre-licensure studies of MMRV vaccine among children aged 12 to 23 months observed that fever and measles-like rash were reported at a significantly greater rate during 0 to 42 days following vaccination in children who received a first dose of MMRV vaccine than in children who received first doses of separate MMR vaccine and varicella vaccines at the same visit. Fever was observed in 21.5% of MMRV vaccine recipients compared to 14.9% of separate MMR vaccine and varicella vaccine recipients, with a risk difference of 6.6% and a 95% confidence interval between 4.6% and 8.5%. In light of these findings, CDC and Merck initiated separate post-licensure studies to evaluate if an increased risk for febrile seizures might be associated with the first dose of MMRV vaccine. Next slide. The following slides describe findings from these post-licensure studies. Next slide. On this slide, post-vaccination interval is shown in the left column. The middle column shows data from a VSD study, and the right column shows data from a Merck-sponsored study. Almost all participants were aged 12 to 23 months. The studies were among different populations and used different methods, yet both found significant associations in the first 2 weeks after vaccination. The VSD, after review of medical records, confirmed an increased risk of febrile seizures during days 7 through 10 after MMRV vaccine compared to MMR plus varicella vaccines. The attributable risk was 4.3 per 10,000 doses administered. The Merck-sponsored study also observed an increased risk of febrile seizure during days 5 through 12 after MMRV vaccine, with an attributable risk of 3.8 per 10,000 doses administered. During the 0 to 30 days post-vaccination, the observed relative risk for the VSD study was 1.4 with a 95% confidence interval of 1.1 to 2.0. For the Merck-sponsored study, the relative risk was 1.1 with a non-significant confidence interval. Next slide, please. This slide shows outpatient visits in VSD for fever after vaccination among children aged 12 to 23 months during 2000 through 2008. The x-axis shows days after vaccination, and the y-axis shows the number of outpatient visits for fever per 100,000 doses of vaccine. The different colored lines represent the different vaccines. The chart shows that visits for fever increased after any measles-containing vaccine during days 7 to 10 after vaccination. The greatest increase occurred after MMRV vaccination. Temporal scan statistics revealed significant clustering during days 7 to 10 for all measles-containing vaccines, all with a p-value less than 0.001. There were no temporal clustering of fever visits after varicella vaccination alone. Next slide. This slide shows the same data, but for number of seizures after vaccination among children aged 12 to 23 months during 2000 through 2008. As with outpatient visits for fever after vaccination, seizures after any measles-containing vaccine peaked during days 7 to 10 after vaccination, with the most seizures after MMRV vaccination. Temporal scan statistics revealed that seizures clustered most significantly during days 8 to 10 after MMRV vaccination, with a relative risk of 7.6 and a p-value of 0.001, days 7 to 10 after MMR and varicella vaccination at the same visit, with a relative risk of 4.0 and a p-value of 0.001, and days 7 to 11 after MMR vaccination alone, with a relative risk of 3.7 and a p-value of 0.001. No seizure peak or significant temporal clustering was observed after varicella vaccination alone. Next slide, please. When we examined the biomedical literature for post-licensure data on febrile seizures following MMR or varicella vaccination, one study identified a significant increased risk of febrile seizures during 8 to 14 days after vaccination as compared with unvaccinated children. The results suggested approximately one additional febrile seizure for 3,000 to 4,000 children vaccinated with MMR vaccine. No increased risk of febrile seizure among children aged 12 to 23 months after varicella vaccine was observed during the 0 to 30 days after vaccination. Next slide, please. A systematic review and a meta-analysis published in 2015 addressed risk of febrile seizure following MMRV vaccination and included studies that used Priorix Tetra MMRV vaccine or Proquad MMRV vaccine. The analysis included both clinical trials and post-marketing observations. Some studies included participants as young as 9 months of age. The clinical trial review and analysis showed no significant differences in incidence of febrile seizures between MMRV and MMR with or without varicella vaccine after any doses across multiple risk windows. Additionally, receipt of concomitant use of MMRV and other pediatric vaccines was not shown to be a significant predictor of febrile seizure. However, post-marketing review and analysis showed an approximate twofold increase in risk of seizure or febrile seizure during 7 to 10 days or 5 to 12 days after MMRV vaccination in children aged 10 to 24 months. Next slide, please. A Cochrane review of MMRV in children was published in 2021 and included analysis of risk of febrile seizure after MMRV vaccine compared to separate MMR and varicella vaccines. The analysis included 5 cohort studies, 4 of which addressed first dose vaccination only. Overall, there were significant findings of increased risk of febrile seizure in children receiving MMRV vaccine compared to separate MMR and varicella vaccines during the 0 to 42 days following vaccination and during the 7 to 10 days following vaccination. The review also analyzed the risk of febrile seizure after MMRV vaccine grouped by brand compared to separate MMR and varicella vaccines. Of the 5 cohort studies included in this analysis, 1 studied Priorix Tetra MMRV vaccine and included the study's original findings as well as post hoc explanatory analysis of results. The findings for risk of febrile seizure with Priorix Tetra MMRV vaccine compared to separate MMR and varicella vaccines were not significant. The 4 other cohort studies in the analysis showed significantly increased risk after Proquad MMRV vaccine compared to separate MMR and varicella vaccines during the 0 to 42 days following vaccination and 7 to 10 days following vaccination. Next slide, please. In summary, post-licensure studies, both in the United States and in Europe, have assessed febrile seizures in children aged 12 to 23 months who received the first dose of MMRV vaccine and compared to children who received separate dose 1 injections of MMR and varicella vaccines at the same visit. Despite using different methods, populations of children and different formulations of MMRV, the studies show remarkably consistency in findings. Next slide, please. In conclusion, studies have identified an increased risk for febrile seizures following dose 1 of MMRV as compared with dose 1 of MMRV plus varicella only during the 1 to 2 weeks after vaccination. The risk of febrile seizures occurring during other periods after vaccination is similar between receipt of the first dose of MMRV and MMR plus varicella given on the same day. Next slide, please. And next slide, please. MMRV is licensed as a 2-dose series with routine recommendation for the second dose of MMRV vaccine between ages 4 to 6 years. The risk of febrile seizures is lower among children aged 4 to 6 years than among children aged 12 to 15 months. In the Merck pre-licensure trials, lower fever rates were observed among children aged 15 to 31 months receiving the second dose of MMRV compared to after the first dose of MMRV. Similar rates for fever were observed among children aged 4 to 6 years receiving second dose MMRV compared with second dose of MMR and varicella on the same visit. Next slide, please. In the Merck-sponsored studies, among children aged 4 to 6 years, no febrile seizures were observed in either comparison arm. Next slide. In a VSD post-licensure study, very few seizures were identified by ICD-9 codes in the electronic data after measles-containing vaccines, with no significant differences observed 7 to 10 days after MMRV, MMR plus varicella, or MMR alone, although rates were higher after MMRV. Next slide, please. Electronic medical record review of the 4 seizures occurring 7 to 10 days after MMRV revealed that 2 patients were diagnosed with afebrile seizures and 1 record was considered improbable as whether fever or an acute seizure had occurred was unclear. Thus, only 1 febrile seizure diagnosis was confirmed, and the absolute risk for febrile seizure 7 to 10 days after second dose of MMRV was 1 febrile seizure per 86,750 doses with a 95% confidence interval of 1 per, with an upper limit of 15,570, or 1.2 febrile seizures per 100,000 doses of MMRV. The upper limit of the 95% confidence interval indicates the risk 7 to 10 days after MMRV is no higher than 1 febrile seizure for approximately every 15,500 doses. Similarly, the risk of febrile seizures 7 to 10 days after MMR plus varicella is no higher than 1 febrile seizure per 18,282 doses of same-day separately administered MMR plus varicella. Next slide, please. The systematic review published in 2015 included analyses of the incidence of febrile seizure and risk following the second dose of MMRV vaccine. Data from pre-licensure studies showed no statistical differences in the incidence of febrile seizure in children receiving MMRV alone compared to children receiving MMRV vaccine and 1 or more other pediatric vaccines at the same visit. Similarly, there were no statistical differences in the incidence of febrile seizure in children receiving MMRV and 1 or more kinds of other pediatric vaccines at the same visit versus those who received 1 or more other pediatric vaccines without MMRV vaccine. The systematic review also addressed the post-licensure VSD study from the previous 2 slides, which concluded that MMRV and separate MMR and varicella vaccines were not associated with increased risk of febrile seizures among children aged 4 to 6 years. Next slide, please. In summary, among children aged 4 to 6 years, data do not suggest that children who received dose 2 of MMRV have an increased risk of febrile seizures after vaccination compared with those who received dose 2 as MMR plus varicella vaccination at the same visit. Next slide. So to conclude, there's a small increased risk for febrile seizures after first dose of MMR and MMRV vaccines. The risk is slightly higher with MMRV combination vaccine after the first dose. Studies have shown a small increased risk for febrile seizures during the 5 to 12 days after a child has received their first vaccination with MMR vaccine. Studies have not shown an increased risk for febrile seizures after the varicella vaccine. There is no increased risk of febrile seizures after vaccination with MMRV vaccine in children aged 4 through 6 years. Next slide, please. I appreciate the opportunity to present these data and be happy to answer any questions. Thank you.
Thank you, Dr. Chu. Thank you, Dr. Chu, for that very clear presentation. I have one question. So you mentioned vaccine coverage rates and that can be affected by whether you take one vaccine or another. And I think you can go maybe in both ways. In one way, children they don't like needles. So fewer needles might mean that it's more likely that they get vaccines. But also, if there's adverse reactions to vaccines, then that can create questions about vaccines, not only among the parents, but siblings or neighbors or cousins. So it seems to me that the aspect of vaccine coverage rate could actually go in either direction. So are there any studies that sort of shows, that quantifies these two things of what coverage could how it could be influenced by the number of needles versus seeing adverse reactions that then get talked about in the neighborhood? And if either of those is bigger than the other, are there any of those studies that sort of try to quantify what those two effects are, which ones is bigger?
So if I understand the question, Dr. Koldorf, you're asking if there is a correlation between vaccine coverage, use of combination vaccines, and occurrence of adverse events. For that, I believe that there may be some experts in the SME room who may be able to address coverage.
Let me ask the SME room, because I know we do have some data. I think, Dr. Koldorf, this might be helpful. There was a survey that was done on parents and providers to get some sense of some of these issues. I don't know if there's data addressing exactly what you're saying, but let me ask the SME room if we could have the backup slide on the survey that was done and any comments you have on this coverage issue. Thank you.
Hi, this is the NCIRD SME room. I don't know if we have data specifically addressing that question. What we do have some data from the National Immunization Survey. This was published in 2024, and this was the National Immunization Survey Child COVID module. It did ask parents to please think about all other routine vaccines, such as those for measles, polio, and tetanus. And then overall, how hesitant are you about those other vaccines for your child? And the results showed that only 14% of parents with children aged 6 months to 4 years expressed hesitancy about those other routine childhood vaccines.
So is that among the parents whose child had a febrile seizure, or what was the population there?
This was a random digit dial survey, so children, all comers, not specifically targeted towards parents whose children had a febrile seizure.
So my question is, if a child has a febrile seizure, it's one of 2,000 who has a febrile seizures because of MMRV instead of MR plus V. So how does having the child having that febrile seizure, how does that affect the parents' willingness to give children subsequent vaccines for that child, or vaccinating the siblings, the younger siblings later on? Or how does it affect, because they're going to mention this to the neighbors or the people in the preschool or whatever, how does it affect sort of then their friends, the neighbors or friend circles, or their siblings' tendency to get vaccines, or their cousins or whatever? So that the fact that there was an unnecessary febrile seizure, how much that influenced the hesitancy or tendency for others around them, as well as their family, to get vaccinations, because that affects the coverage. It's not just the number of needles, that also affects the tendency to coverage of vaccines.
Yeah, thanks, Dr. Koldover. This is Sarah Oliver back in the NCRD SME room. If we could go back to the background slides from our presentation, it's a slide 27 from the background on MMRV presentation. So I would say we don't specifically have data from a survey where children had previously had febrile seizures. However, the work group in 2008-2009 that was discussing this, there was a survey specifically for parents. Yeah, slide 27. There we go. There was specifically a study among mothers who asked, where this question was asked. You can see that down there at the bottom, it said almost a third of mothers would be resistant. About a quarter were neutral, and around 40% would accept. So it really was a range across the board. What I would say is that when the work group discussed this previously, and what we know from vast experience with vaccine administration, is the best discussions about vaccination and risks and side effects occur between the pediatrician and the child and the parent. So what the decision was at the time was that the parent should have the choice and should have the option for MMR and varicella separately, or the MMRV. The risks were made known, and the recommendation from CDC was that the pediatrician include that in the discussion, but that the parents should have that discussion. So the pediatrician is the best one who would be able to understand that family and know the balance of benefits and risks for that specific child in that specific situation.
Thank you. No, I understand that we don't. Thank you. I understand that we don't have data and that it's very hard to sort of quantify how much vaccine hesitancy would increase through these additional febrile seizures. So we have a few other comments. We have Dr. Cody Meissner first.
Thank you, Dr. Kulldorff, and thank you, Dr. Su, for your presentation. I will just add the perspective that this discussion is really a deja vu for me, because we had extensive discussions on this very topic 15 years ago, approximately. And it's one of the very few settings where the recommendations from ACIP differed from the recommendation from the American Academy of Pediatrics. That is, the ACIP felt that the doctor could administer an MMR plus a V. And it was interesting, the American Academy of Pediatrics did not express a preference for the 12 to 15-month-old dosing of these vaccines. The feeling was that, and I remember that someone did a calculation, and a pediatrician who had a busy pediatric practice would perhaps see one patient who had a febrile seizure after receiving MMRV at 12 to 15 months, rather than the two being separated. So first comment. Second comment, and Dr. Su and Dr. Oliver, correct me if I'm wrong, but I think of febrile seizures after just an MMR vaccine given at 12 to 15 months as about 1 per 3,000 doses. Am I correct on that? And so if one uses, instead of MMR plus V in two different arms, one administers MMRV in one arm, the risk of a febrile seizure is essentially increased by twofold. Is that a reasonable way to think about it? Thank you.
We can see slide 13, please. So in this slide, previous studies have demonstrated that after MMR, there is an observed additional risk of 1 per 3,000 to 4,000 children vaccinated. So when you say twofold increase in risk, that is correct, sir.
Right. And then the other point regarding an MMRV at 4 to 6 years of age is that, and I think you said this, that more than 95% of febrile seizures occur before 4 years of age. It's only a couple of percent that occur in children after 4 years of age due to any cause. Is that correct?
I would ask for the SME room to provide details, but I'd say that risk of febrile seizure after 5 years is rare.
Thank you.
Thank you, Dr. Ratsevlawai.
Yeah, three quick thoughts. And so just to follow up on the first question by Dr. Koldruf, I would think that there should be data on this, right? Like we know which, it's probably documented diagnosis, which children had the seizure, and we know what their future, what after that, what vaccines they took and when. So I think we can actually, we don't need service for that. We can just look on the data. And I guess that's also potentially can affect what we see in the second dose, because potentially there's a subset of children that is more sensitive to the immune response to these vaccines. And since they experience such an extreme response after the first dose, maybe they don't go to the second dose as quickly or not at all. So I just would caution the fact that we don't see after the second dose does not necessarily mean that there is no potential mechanism here, but potentially it's a kind of a survival bias thing. But maybe one thing that bothers me is that we are focusing on symptoms, and I'm not sure we have a good mechanistic understanding of what's going on here. It seems that on the face of it, it seems that there is one vaccine with higher level, higher dose, higher quantity of the antigen that seems to cause, at least for some of the children, a more extreme immune response. And we are measuring it through fever and seizure, but potentially there are other things that are going on. So my question is, did we ever test those children that had the seizure to see if they have a unique immune response with other biomarkers that just to try and understand the mechanism of what's going on here? Because from a safety perspective, I'm very concerned when we just focus on what we measure and we don't try to get to understand the biological mechanisms that are taking place here. And yeah, I know it's not easy, but it doesn't look like we are making any real effort to understand this.
I'd like to echo that, because children who are very young like this may have a heightened IL-1. IL-1 is the cytokine that causes fever. And so the question for the manufacturer and for those who study this is whether IL-1 or other cytokines were measured in the serum of these children who were febrile. And did they look at cytokine gene polymorphisms or other genetic predispositions to febrile responses, which then segues to your second concern, is that looking at downstream at the second dose, there may be a selection bias in eliminating those children, because most pediatricians, to the best of my knowledge, will not revaccinate somebody who's had a prior history of febrile seizures. So we may be looking at a selection bias in looking at the second dose. So the question then for what we would have to consider as a recommendation is what to do with the child who has had a history of febrile seizures. How do we manage their vaccination schedule the second time around?
With regard to biological mechanisms?
Yeah, were IL-1 levels measured by Merck or any other investigators in looking at febrile seizures or the genetic makeup of these children?
I would defer to experts perhaps in the SME speaker room with regard to biological mechanisms.
And then the second question was to emphasize what Recep said was, is there a selection bias then in looking at the incidence of febrile seizures for the second dose?
So that's we don't have to get a response to every comment here, so that's perfectly fine. I think that Dr. Lever's comment is excellent, that the data is there. If you wanted to look at if the effect of a febrile seizure in the child, that affects either subsequent vaccination for that child or vaccination for the younger siblings. I don't think that has been done, but it's certainly the data exists if you wanted to do it. I think next on the list is Dr. Milhon.
Yes, thank you. I just wanted to remind everybody that a febrile seizure is diagnosed retrospectively. A seizure happening to a family for 15 minutes is an enormous long time for a child to seize. So just when we talk about these things, and do I see in my practice that if a family has had a febrile seizure, are they excited to get the next vaccine? No. Am I excited to give them the next vaccine? No. It opens my eyes. Do we know that a natural occurring fever from a viral that is brought on not through a vaccine has the exact same mechanism as a fever that comes upon by a vaccine that is for a virus that in rare cases causes encephalopathy? We know that increasing temperature decreases the seizure threshold in all people. Right? That's well known. Is there an additive from the measles vaccine decreasing the seizure threshold more? So I think that's a question that's reasonable to ask, but to your point, Dr. Kulldorff, I think families are very concerned. I think there's an increased hesitancy through all families right now. And I think that that's what we're here to do, is try to give them the best risks, benefits of these things as we can. Do we know, have the febrile seizure children seen first dose? Do we have a long-term follow-up on all those kids?
The ask of us was to present data on risk of febrile seizure. I would have to go back and look at data with regard to longer-term outcomes.
Thank you. And next on the list is Dr. Stein.
Thank you. So I'm curious how the risks are communicated. Like, how is that actually done? Because I find it striking that a lot of this data you have existed before the guidelines, and so the guidelines were informed by those data. And then you also presented a lot of data that have been generated and published after those guidelines. And so I'm curious, since there is a parental choice here, how is that risk communicated to the guardians?
And they ask if anyone in the SME room has the knowledge of that from the MMWR. Was there language in there on how to communicate, or has CDC produced documents on how to communicate? I'm not sure. I'm seeing if anybody knows.
Yeah, NCIRD SME room. We developed one-pagers for providers, how to talk to the parents. It was in a table format. These are the risks, these are the benefits, this is what it means. And we also, I think we developed a one-pager for parents to be aware of this increased risk with MMRV versus MMR plus V. So yes, we provided, call them communication materials to help pediatricians discuss this risk in a way that the parents would understand.
And this is Dr. Oliver. If we look at the usage data too, we know that 85% of the kids who are getting these vaccines are getting them separate at that first visit. So it's 15% kind of on average of kids that are getting MMRV at that first visit. Presumably after, again, the discussion with the pediatrician and the provider over kind of the risks and the benefits. Thanks.
Thank you. Next on the list is Dr. Griffin.
Thank you. Thank you for your presentation. There are studies that are suggesting lasting neurologic impacts in children. So I was wondering if there are any studies that the manufacturer or others are performing for children education performance.
You mean children after seizure?
After febrile seizure, I'm sorry, yes. And I have a comment afterwards.
Okay, I would again defer to experts within the SME room, please.
Hi, this is Julianne G. From the SME room. We are not doing any long-term safety studies, but if the manufacturers are available, they may want to comment on this.
And my comment to this would be, the product has been licensed since 2005. It would be helpful for parents to have that awareness or that reassurance that these studies are performed. A secondary question I would have is, are any of these studies tested against a true placebo, a saline placebo?
I'd have to get back to you on that one. There are most of the studies that I've seen are in comparison with MMRV versus MMR plus varicella separately. There were one or two studies where, well, I'll hold over there and I can get back to you with a firmer answer if desired.
It is difficult to decipher then the risk if we're comparing MMRV versus MMR plus V. Then does this not automatically hold us to a confounding factor? The retort to this typically is that it is unethical to hold a vaccine versus true placebo study because it's unethical, because the sentiment is that the vaccine is considered safe and effective. However, I think that is probably the most ethical thing to do in a day and age where parents are, through full informed dissent, not getting their children vaccinated. And I will share from a perspective, I have seen parents who have opted to not vaccinate their children be some of the most educated people I have spoken with, bringing in studies and showing their rationale for not vaccinating. And so in this day and age where we do have, I feel that it is ethical to invite those parents for such a study and say, okay, since you are making this informed choice, let's study this. So I think I would invite that idea to have a true placebo study. Thank you.
Let me ask the IRD SME room if they have a comment on on this issue. Thank you.
Yes, we'd like to add that a placebo study would be a randomized control trial. And in that case, you cannot, if you select only people who avoided vaccination or who expressed an interest to not being vaccinated, there may be confounders introduced. They may, the children, maybe they had some experience with adverse events, so you cannot select participants based on their willingness. They have to agree to be part of either the study group or the control group.
Yeah, the point of a randomized controlled trial is that they have the exact same likelihood of receiving the placebo or receiving the vaccine. So the families would have to consent to that. And I think at a time where we're seeing the highest measles cases we've seen in many years, it would be concerning to ask parents to risk the chance that they would receive a vaccine that would not end up protecting them from measles, mumps, rubella, or varicella disease.
Yes, thank you. I do appreciate that answer. I would push back that in today's day and age, parents are asking for more such studies, and even if it is in more observational studies of vaccinated versus unvaccinated, that the populace would welcome this.
Thank you. Just one comment. One way to do ethical vaccine trials with a placebo control is to randomize them to the timing of the vaccine. Different countries recommend the MMR vaccine at different age. So one could randomize it, for example, giving them at age 12 months versus giving them at age 18 months, for example. So one can do randomized placebo-controlled trials in an ethical manner to also then, so that's possible. But we'll continue with the list here. Dr. Blackburn?
Yeah, so in reviewing the studies on MMRV or MMR plus V, I noticed that they were designed with both vaccines given on the same day. Could you explain the rationale for conducting the trials this way? Wouldn't simultaneous administration of the MMR plus V yield similar adverse results, similar febrile rates as the combination product MMRV? Whereas evaluating these vaccines when separated by at least 28 days might provide clear insight into differences in potential adverse reactions. Given that the typical pediatric visit schedule includes visits at 12, 15, 18, and 24 months, there would be opportunities to administer the vaccine separately, and was that considered in the study design?
I'll ask if anyone in the SME room knows if that was considered in the study design.
The studies were designed to compare MMRV with MMR plus V because MMRV is designed to replace two vaccines or two injections in one. So the comparison needed to be between the what if we give them separately, what if we give them in the same syringe. But there are some studies, the same studies looked at comparing with the MMR arm, with an MMR arm or with a V arm. But the bulk of the studies were comparing the two vaccination options to see if you give one injection, would you get the same immunogenicity? How would the adverse events be? For the vaccines, then you don't need a combination vaccine. You can give MMR at 12, you can give varicella at 15, but that would not be replaced by one injection. The children will still get two injections.
Thank you, Dr. Pemsworth.
I have a question and a comment related to the vaccine information statement for MMR, MMRV. Is there language in that statement that prior febrile seizure or seizure of any sort after vaccination is contraindicated? I'm not sure. I somehow don't think that it's a contraindication. This goes to the informed consent issue. Also, I noticed, and to what Dr. Pollack mentioned about selection bias in potentially what we're seeing, the data related to the second dose of MMRV at age 4 to 6 years of age. I noticed that the VSD data did note both febrile and afebrile seizures, although it was not statistically significant, but it kind of raises the question about non-significance, maybe because of selection bias, but also I feel like we need to address the assumption, it sounds like, that febrile seizures are largely benign. I'm not sure what the clinical significance is of these seizures. What do we know about them? And is this goes back to, should that end up being a contraindication to ever getting that vaccine again?
So with regard to the information statement, I would defer to the information statement, the information contained therein. If there's an SME on the line, perhaps someone could indicate if it's on there.
Go ahead. We have a comment, question on the vaccine information statement. Let me ask the IRD SME room to comment on that. Thank you.
Yes, we can report that the vaccine information statement for MMRV does contain a sentence that says, talk with your healthcare provider if you have a history of seizures or has a parent, brother, or sister with a history of seizures. Contraindications are set by FDA.
And also in the same VIS, under risks of a vaccine reaction, there is a bullet with a few sentences. Seizures, often associated with fever, can happen after MMRV vaccine. The risk of seizures is higher than after separate MMR and varicella when given as a first dose. And then your healthcare provider can advise you of the appropriate vaccines.
Thank you, Dr. Meissner.
Thank you. Thanks, Dr. Kuldorf. 2 points I'd like to make. First of all, febrile seizures occur in 3 to 5% of all children. They're common. And every pediatrician is experienced in febrile seizures. And we know that the prognosis is excellent. The major concern, as Dr. Kuldorf has pointed out, is the anxiety it generates in other family members. And that's entirely understandable. And it's a very frightening experience. But I think people are very comfortable in saying that a febrile seizure is not associated with any sort of impaired performance or neurocognitive development or school problems. It's I don't know if I can call it a frequent occurrence, but every pediatrician is quite familiar with febrile seizures. Number two, the issue I think we're discussing, it really comes down to, should parents get 2 doses or should they get 1 dose of these measles, mumps, and rubella and varicella? And the disadvantage of giving 2 doses, or as was suggested, separating the 2 doses, is that we know compliance falls. And the advantage of combination vaccines is that children and adults are more likely to complete the vaccine requirements if it's given as a single dose. So the second, and then the reason, the argument against giving MMRV at 12 to 15 months is that there is this very slight increase in febrile seizure activity. And I think the way it is currently stated by the ACIP in the MMWR is quite appropriate. If a parent is more concerned about a febrile seizure, she can have the vaccine administered in different arms. If she's not, if she's more concerned about reducing the number of immunizations by 1 dose, she can have the combination vaccine. And I think, as Dr. Oliver pointed out, about 85% of children are now receiving a vaccine in each arm, and that's fine. I think, I mean, I'm not quite sure where we're going with this discussion. I think that the current wording is appropriate. Over.
Thank you. And Dr. Asaf-Levy?
Yeah. So I guess I feel a little bit unease because it seems to me that we are making a lot of assumptions that we really understand what we are seeing. And I want to remind ourselves that we call, a lot of the time it turns out that we call different things the same just because we did not understand the underlying mechanisms that could be very different, but the way we measure them made us believe that we're actually seeing the same thing. So I think just building on the comment that we heard before, it's not clear to me that a seizure, febrile seizure that comes after a viral infection is the same as what we are seeing here. And I think we need to investigate that because if it's not, potentially our assumptions about the long-term and the short-term implications may not be true. So I think we need to adopt a little bit a safety approach that doesn't just limit ourselves to what we measure, but also recognize that what we measure is limited, and we need to try and understand the mechanisms. And I have to say, I'm listening to discussion, and my impression is that we don't really know what's going on, other than that the fact that a vaccine that has a higher level of antigen seems to cause more frequent events like this. So I would really encourage all the agencies that are responsible for this to really launch more investigations that include some measuring the kids that had seizures and following them long term. I don't think we can just stay with the mindset that safety of vaccines is limited to the 30 days, 40 days after vaccination. Because the essence of vaccines is actually to make long-term biological impact on our body and give us long-term immunity, which is the benefit. But if we assume that the benefit is long-term, I think we also need to consider the fact that some of the adverse impacts could also be long-term.
Can I, Mark, answer, Dr. Ritzef?
Yeah.
And I thank you for that comment. I think it's a very well taken point, Ritzef. My response is that febrile seizures are pretty well defined. We know, for example, that a febrile seizure obviously occurs when a child, usually less than 5 years and usually less than 4 years of age, has a fever. It's a generalized seizure. That is, it doesn't involve one limb or another. We know that it lasts, it's been defined as lasting less than 15 minutes, and usually they last just a few minutes. So they also do not recur within 24 hours as part of the definition. So we have a pretty reasonable definition of febrile seizures, and the vast majority of febrile seizures do not occur in association with vaccines, as we're saying. So just for one, I'm not sure putting limited resources into this activity will give us the greatest bang for the buck. I think that we're so familiar with, as a pediatrician for more than 30 years, we're so familiar with febrile seizures, and I think most pediatricians would say that the prognosis is excellent, apart from the emotional impact on the family. Over.
Thank you. We have time for two more persons, and then we're going to have to end so we can move forward to the statement from the vaccine manufacturer. So the next is Dr. Mulholm.
Thank you. As someone, I'm not sure how many on this committee actually do an electronic medical record. I know that there's a lot of dependence on the ICD codes that are generated. And I've heard that some people consider if there is an ICD code generated on a certain condition of a child, then that didn't happen. I will tell you, as a practicing physician, the amount of time I can spend trying to look up ICD codes to make sure that every one of them is there and exactly the precise ICD code that the child has is often time prohibitive. I think that it's important that when we look at data, we look at clean data. And I think the cleanest way to have clean data is to have an ICD code that is febrile seizure temporally related to a vaccine. And then you have a febrile seizure that's not. If we're going to be looking retrospectively at ICD codes, I think this is very important. But I also encourage people who are not in clinical medicine, who are using ICD codes to generate research, that these are not perfect. These are not a perfect data set. So those are my thoughts.
Thank you. And the last now from Dr. Petsworth.
I just want to thank you, Dr. Meisner, for your comments and your clinical expertise on this. But I want to push back just a little bit and note that there is a study out there published in 2023, the long-term neurodevelopmental outcomes of febrile seizures and underlying mechanisms, that states both clinical and animal studies show that febrile seizures have detrimental effects on neurodevelopment that cause attention deficit hyperactivity disorder, increased susceptibility to epilepsy, hippocampal sclerosis, and cognitive decline during adulthood. However, the mechanisms of febrile seizures and developmental abnormalities and disease occurrence during adulthood have not been determined. So it goes on, but I think this is a topic that merits being put on the agenda at some point to evaluate as part of the safety work that we need to be paying attention to.
Thank you so much, and thank you for a very good discussion. And again, thank you for that presentation, Dr. Su. The next one is, I think we have a comment from the MMRV vaccine manufacturer. Are you on the line?
Yeah, can you hear me okay?
Yes.
Yeah, thank you.
Please go ahead.
Yeah, this is Rick Haupt. I'm the head of infectious disease and vaccines, medical and scientific affairs at Merck. And for the record, I'm a pediatrician and saw many children die from infectious diseases that included pneumococcal, Hib, and varicella. And now these are all vaccine preventable. I'd hate to go back in time to a period when we saw invasive diseases. ProQuad MMRV has been evaluated through well-designed, high-quality clinical trials and post-licensure effectiveness and safety. And those data have been shared with regulatory authorities, public health agencies, medical societies, and have been published in journals. This issue of febrile seizures, the slight increased risk after the first dose, was initially described by an observational study that we conducted with Kaiser in 2009. So this has been something that's been well described for 15 years now and has led to the current recommendations, which are that there is no risk for the second dose. So it's preferred to give MMRV for the second dose. But for the first dose, the preference is for separate MMR and varicella vaccination to be given. But the language allows for a provider and or family to select MMRV as the dose given in the first dose. As we've discussed this morning, that has led to about a 15% utilization, but the vast majority of children receive separate MMR and varicella at 1 year of age. It's important to note that evidence indicates, and major public health organizations and professional societies agree, that combination vaccines improve completion and on-time vaccination, leading to higher adherence and fewer delays in disease vaccination, or disease prevention, And recent CDC surveillance data reveal a troubling decline in kindergarten vaccination coverage, where rates for measles, mumps, and rubella, potentially serious and fatal diseases, have fallen below 95% threshold, which is required to sustain measles herd immunity. Considering these trends, any policy decision that compromises the clarity or consistency of vaccination guidance for MMRV has the potential to further diminish public confidence. I think that's really important in your deliberations, and I thank you. I can go back and answer some of the questions that you may have had for us. The one point I would make is that there was one question about what do we understand about the immune response and why was there a higher amount of antigen for varicella that was put in MMRV. And it's important to know the increased antigen was only for varicella. There was no change to the antigen content for MM or R in the combination vaccine. And it's essentially related to what was needed to demonstrate an appropriate immunological response to show non-inferiority of the immune response of MMRV compared to the separate MMR and V. And it's very likely that this relates to local interference of the antigens when they're given in the combination product. That's all from me. Thank you.
Thank you. I would like to make one correction to make sure that deserves the credit for finding that out. It was done through the Vaccines Data Link and its rapid cycle analysis, where the CDC evaluates new vaccines with weekly data feeds. And it was detected, I think, after about 25,000 doses. So it was a very quick detection, and it shows the excellent work that people here at CDC and in this particular VSD is doing to monitor the safety of vaccine. Are there any other comments or questions on this presentation? Dr. Hibbelin.
A brief comment concerns that we are looking at a risk benefit of febrile seizures, which may or may not have long-term consequence, likely not, as compared to falling below a 90% coverage rate for herd immunity. And the consequences of that are devastating for pregnant women losing their babies, newborns dying, and having congenital rubella syndromes. And that it seems that we have to be very careful of driving this non-vaccination group below 90%. Appears we have to be very conscious that this may be driven by fear and may be driven by most people, the fact that most people don't think about, they think of vaccines being either good or evil. And either I should have my child vaccinated or not vaccinated. And they don't understand the discussion of the subtleties that we're going through. So if we make a major change in what has been a very vaccine campaign, I think we have to have a darn good reason as to why we're making that change from what Corey Meisner about and access. We had better have a very good reason as to why we'd change that advice.
Thank you. And I think we can move forward now to the proposed recommendations and a discussion of those. If we can get those proposed recommendations up on the screen, that would be great. I would like to stress that in this vote, we are not voting on any changes in what diseases children are vaccinated against, nor are we proposing any changes in the timing of these vaccines. So that's not part of the vote or discussions. One can have different views on that, but that's not part of what we're doing today. So the vote is on the pediatric vaccine schedule should be updated to reflect the following change. For measles, mumps, rubella, and varicella vaccines given before age 4 years, the combined MMRV vaccine is not recommended. And 2, children in this age group should receive separate measles, mumps, rubella vaccine, and varicella vaccines, MMR plus B. And again, we are neither voting on children above 4 to 6 years because we know that there's no difference in the risk of seizures among those older children. So this is the vote, the proposed vote, and do we have the discussion now then, before we do? Oh yeah, okay. But we have the discussion now of this, and we're voting not until the end of the day after public comments. Dr. Stein?
Could you clarify how this is different than the current recommendation? Because that the 2009 recommendation sounds like the two separate shots.
So there's two main differences. One is that the current recommendation says that both are recommended with the preference for MMR plus V. The other one is that some children get a second dose before age 4. For example, if there's an outbreak, a child might get a dose at 7 months of age, but then they have to be, because it doesn't have the efficacy, so it has to be, then get a dose again at 12 or 15. So then that's the second dose. So they will also, so right now, so they will also change so that everybody who gets the dose, whether it's the first or the second dose, it will be not, MRE will not be recommended, whether it's first or second dose. Those are the two differences. Dr. Levi?
Yeah, so the way I think about it is, let's say that someone would guarantee us that the adherence would be the same. Let's just for the sake of discussion. It seems to me quite reasonable that most of us would think that the separate vaccines are better because there is some harm or adverse events that are being caused in excess. I think some of us maybe feel more kind of comfortable that they know and they understand that it's just like a local impact of that event, and some of us are more concerned. But I suspect that if we would somehow be guaranteed that all things are equal between these two options, the adherence is the same, I think the choice would be clear. So that kind of brings to me, in my mind, the discussion to what extent we believe that two separate doses are going to have materialistic impact on adherence. And I'm not fully convinced which factor. We are all concerned on reduction in adherence to vaccines, but it's not clear to me that the fact that we see a reduction suggests that the reduction would come or would be affected by the fact that we separate these two vaccines for the first dose. In fact, I actually tend to believe more that safer and less adverse events are going to increase trust and adherence. So that, given that at the very best, I don't think we have good evidence either way, I would go with the option that seems to be safer, that also gives lower quantity of the antigen to the children. I think that that's something that makes sense to me.
Thank you, Dr. Petsworth.
I just want to clarify that currently 85% of the first dose is MMR plus V. So we're talking about 15% of vaccinations at 12 to 15 months is currently MMRV, correct? Okay.
Yes, that is correct. And I want to sort of give praise to the pediatricians because they have both options, but 85% is choosing to administer the MMR plus V because of the fewer seizures. And just an anecdotal thing, when my twins were vaccinated, I asked the nurse if it was the MMR V or the MMR plus V, and she said, "Oh, it's the MMR plus V because," and she gave us exactly the correct reasons for why that is the case, without knowing that I do vaccine stuff. So she knew her stuff, and of course the physician in the office knew his stuff. So I think we should praise the pediatricians and the nurses who are 85% are sort of trying to minimize these febrile seizures. I think we're actually a little bit ahead of schedule, so that's good. Oh, okay, Dr. Meissner.
Thank you, Dr. Kulldorff. And let me make two comments here.